So I'm Manudeep Kalra and I'm from Mass General Hospital in Boston, and I'll be speaking on abdominal CT, when to dial up and down the dose meter. So these are my financial disclosures, and I have to say that this presentation has been made possible from a grant from the Radiological Society of North America in 2010 to 2012, and I have received some remuneration from GE Healthcare. So, well, why do I have a chest CT slide in the abdomen talk? Well, the reason is that radiation dose can be significantly reduced for chest CT, and that's because there is high contrast, which is basically because there is air in the lungs, and that actually helps you pick up the lesions at much lower levels of radiation dose. As you can see from here, this is only 1.3 milligray acquired at 18 MAS. You can still see those 3 millimeter nodules here in the lungs, and you can still see those opacities in the left lower lobe. So basically, high contrast actually helps you reduce the dose significantly, and that actually takes us to CT colonography, because like lungs, the CT colonography, in which the colon is actually distended with air, also has high contrast, and that helps us dial down the dose meter. This is an example of a flat polyp which is about 8 millimeter, and it can be seen at much lower level of radiation dose. This CT was done at 100 kV and with an MAS of 40. So as you can see, we can say this a small flat polyp at very low levels of radiation dose between 2 to 4 milligray is sufficient, and that's because this is a situation with high contrast, and therefore we can turn the dose meter down. What else is high contrast in abdomen? Well, kidney stones, again, calcium versus soft tissue. That's another place where there is high contrast, and therefore the dose can be dialed lower. This is a cadaver which we scanned at 5 different dose levels. As you can see, there is a tiny 2 millimeter calculus in the left kidney. There is no hydronephrosis. You can clearly see the kidney stone at 3.4 milligray, which was basically 50 MAS at 120 kV. You can see it as clearly as you can see the kidney stone at much higher dose of 30 milligray at 300 MAS, which basically tells us that you can actually scan these kidney stone patients at much lower levels of radiation dose. Although it's very difficult at that dose level to see anything much in the liver, you can still see the aortic calcification. You can still see some vascular calcification in the region of the pancreatic tail and also in the branches of the aorta. So, for scanning patients with kidney stone, typically 120 kV is used. Now, people are applying more and more lower kV, for example 100 kilovolt in patients, specifically those that are smaller than average patients, like patients who are less than 60 kilogram. And we should actually prefer automatic exposure control technique or automatic tube current modulation over fixed tube current, because it helps cut the dose down. But we have to remember that when we are using AEC, we have to use it so that we get about 30 to 50% lower dose than what we get from a routine abdominal CT. And typically the image slice thickness would be about 2.5 to 5, depending on where you are practicing. We use 5 millimeter slice thickness for our kidney stones. And typically, depending on the patient's size, smaller patients can be scanned easily at 2 milligray, and bigger patients may require 6 milligray. Another important thing is that a lot of these patients undergo a follow-up CT, at which time the dose can be reduced even more than what you would have used for their first kidney stone CT. And again, as I said, calcium and kidney stones and anything calcified can be seen at considerably lower levels of radiation exposure. And this calcium can be anywhere from vascular calcification or in the kidneys, or in this case, gallstone. Of course, this fortunately is not an indication for doing CT, but just to make a point that calcification, regardless of their location, can be scanned at much lower dose levels, and therefore the dose meter can be dialed down. On the other hand, this patient also has some free fluid in the abdomen, as you can see here, very well seen at doses of 30 milligray, 24 milligray, 13 milligray, and then as you go down below that double-digit number, it begins to fade with the liver until at 3.4 milligray, it's somewhat harder to see that. So if this was smaller than what it is at the moment, it will be hard to see this free fluid in the abdomen. Bone lesions, again, because of the high contrast, can be seen at very low levels of radiation dose. In this case, it can be seen at 3 milligray, and these images have been acquired in the postmortem settings, and they have been reconstructed at 5 millimeter using filtered back projection technique. So again, when you are assessing just the bone lesions and you're looking for lytic or blastic lesions or something like that, the dose can be considerably lower than in other places. So what else is higher contrast in abdomen which can afford us to reduce dose? CT angiography is another place which can actually allow us to reduce dose. Now remember, many times we do multi-phase exams when we are doing CT angiography, like non-contrast CT, before we do an arterial or venous phase of enhancement. And in that situation, the non-contrast phase should be acquired at much reduced radiation dose, something like a kidney stone protocol or even lower, because you're looking for calcium or hemorrhage or stent basically, and those can be assessed at much lower doses than what you would need for CT angiography. In CT angiography, before we do them, we have to know that because we are giving iodine or contrast to the patient, there will be high contrast, and when we are doing a contrast enhanced study, it's perhaps more optimal to actually use lower kV than it is to use higher kV, especially in patients who are average size or smaller than average. So this is an example that has been taken from a paper in Investigative Radiology by Dr. Sebastian and his colleagues. And here we see that the images have been acquired at 100 kV with 60 cc's of contrast at 7 milligray. And then the next set of image in the middle row the middle column have been acquired at 80 kV at 5 milligray with 60 cc's of contrast. And the interesting thing is that when we use lower kV, we can not only reduce the dose, we can not only improve the contrast in the image, but we can also use less amount of that contrast. So this can be important for patients with renal insufficiency, or where we can only use a smaller amount of contrast because of other things. And now importantly, an 80 kV is something that I would use in abdomen only in patients who are very small, and preferably if I have some kind of iterative reconstruction technique, because otherwise the noise or the artifacts sometimes can be prohibitive for good interpretation of images. Another place which may have a higher contrast, depending on how we do it, is basically CT enterography, in which we basically would give some oral contrast, which can be negative or positive contrast agent, but regardless, it does help improve the contrast in the images. And therefore, this is another place where we can actually acquire the images at a lower dose, either with the reduction of MA or with reduction of kV. These images have been taken from an article in AJR in 2011 from Lee and his colleagues, where they have shown that with application of iterative reconstruction technique, as is seen in the last column, there can be up to 50% dose reduction using lower MAS and hybrid iterative reconstruction technique IRIS, which is from Siemens. So, well, not always we have to reduce dose in abdomen. Sometimes we need to see lesions that are subtle, or perhaps lesions that are in patients who are significantly ill, where radiation is not that much of an issue, as is the fact that we need to be able to see, localize, and characterize a lesion. For example, patients who are suspected of having liver or pancreatic masses, right? These exams frequently have higher doses, and you do need to dial the dose meter up for these patients if you want to get sufficient image quality. And often that dose meter does get dialed up because you are going to do more than one single pass through the abdomen, a multi-phase CT basically. And in these situations, the dose can be reduced, although I have to caution you, not at the expense of causing more noisier images. But the dose can be reduced by reducing the kV, which will help you improve the contrast and at times even see these lesions better, while slightly reducing the dose depending on what kV you're operating at. The other important thing in these patients is reducing the scan length to what is needed, and that actually will allow you to reduce. This is an example from our institution. It's a multi-phase exam. We do not acquire, first of all, non-contrast images when we are doing a dual phase or a triple phase liver examination. So no non-contrast images, right? When we do arterial phase imaging, we go to 100 kV in patients who are 80 kilograms or under. I think if you try to apply this to patients who are considerably heavier than that, you may get some artifacts in increased noise. And of course, we do apply iterative reconstruction techniques on top of that. And then the other thing that we do in arterial phase is actually restrict the scan coverage or the scan length to liver only. And then of course apply automatic exposure control technique, because that helps better to adapt the tube current to not only the kV change but also to the size of the patient. And when we have to do the portal venous phase, we will cover the entire abdomen while using a usual kV of 120. This is a result from a paper that was published in Radiology by Marine and his colleagues, where they actually applied 80 kV to see hypervascular liver lesions. And what they found was that if they apply 80 kV, you can see the middle image basically does show the enhancing liver masses very nicely. Application of iterative reconstruction technique does help denoise the image, but doesn't really bring out many lesions that may be missed on FBP images or filtered back projection images. Now these are 5mm slices, and I do think that acquiring these images at lower kV not only helps reduce the dose, which may not be as important in this patient, but also what's more important is actually brings out the lesion because they appear more contrasty or much better seen on the lower kV. This is another from Nakaura and his colleagues, which was published recently in Radiology. And again, they compared 120 kV with filtered back projection with 80 kV images with filtered back projection in the middle row and 80 kV also. And as we can see, that use of iterative reconstruction technique does help denoise the image. But when you are looking for enhancing structures or enhancing lesions, they typically can be seen much better because of improvement in the contrast at lower kV, sometimes even without the use of hybrid iterative reconstruction technique. But then it's important to remember that in this case, you use lower kV to improve the conspicuity of lesion, and one of the things that you get in return is you are able to reduce the dose as well. So what about pancreas? Well, as I said before, this protocol basically pertains to evaluation of pancreatic mass. We should perhaps be doing many of the exams for follow-up of acute pancreatitis with a routine abdominal CT, unless we are looking for something like a vascular complication or other things. Well, one of the things that we do is when we acquire the images in arterial phase, we would restrict the acquisition to just liver and pancreas. So shorter scan length helps to cut the dose down. We would use automatic exposure control technique because that helps us adjust the dose better to the patient size and indication. And of course, addition of iterative reconstruction technique will allow us to reduce the dose by about 30 to 50% as compared to a filtered back projection technique. For portal venous phase, on the other hand, we will actually go through the entire abdomen and pelvis. In this case, unfortunately, they've gone too much into the chest, but we would typically start just above the liver and go down to the pubic symphysis in order to stage the cancer in the pancreas, which is seen here. So this is how we will cut the dose down in pancreatic CT protocol for pancreatic mass evaluation. And once again, it's important that the chest CT be done at much lower dose as compared to the CT of the abdomen, as you can see from here. Adrenal protocol. Now, typically, the adrenal protocol is triggered because we had a chest CT or an abdominal CT, which was done with contrast or without contrast, a single phase study generally, and we saw an adrenal nodule which we could not characterize on a single phase CT. So typically, we already know what exists beyond and above or below the adrenal. So when we get this request to do adrenal protocol CT, the dose will go up, of course, because it's a multi-phase study. We have to do a non-contrast CT, and then we have to do a portal venous phase CT, and then we have to do a delayed 10 to 15 minutes acquisition, right? So the way that we optimize dose in these situations is that we would cut the scan length from top of the T11 vertebral body to the inferior aspect of L2 vertebral body. So all the phases are acquired with limited scan length, and that actually cuts the dose down without touching any of the other parameters that we would have used with a routine abdominal CT protocol. For example, 120 kV, automatic exposure control technique, and iterative reconstruction technique. So the The routine abdominal CT as compared to kidney stones and CT colonography on the other hand have to have higher dose. So the dose meter may have to go higher as compared to the kidney stones and CT colonography indications, and that's because there is lower contrast between the soft tissue lesions that we might see and the soft tissue organs, basically tissues. So therefore the dose has to be higher than what you would use for your chest CT or what you would use for your kidney stone or CT colonography. Now, some of the important aspects of routine abdominal CT is that you have to use automatic exposure control technique for most of them. In fact, I would recommend that all of the exams be done with automatic exposure control technique, unless you see that the patient has got a very large metallic prosthesis which is going to extend through most of the abdominal pelvic region, where the dose can go higher and inadvertently higher depending on which kind of scanner you have. A lower kV, we are seeing that more and more places are actually using lower kV very routinely for even doing routine abdominal CT in average to small size patient. Certainly for scanners that have iterative reconstruction techniques, you can actually do that, and that will actually help you see the contrast much better than what you would see at conventionally used 120 kV. An important aspect is that the arms of the patients should be kept above or outside the field of view of the abdomen, because otherwise the dose will go up and artifacts will happen. If the patients cannot keep their arms above or beyond the abdomen, then do not place the arms by the side of the patient. You need to place the arms most often on the top of the abdomen. You need to keep a pad between the hands and the arms so that they are not touching the abdomen, and this actually will help you cut down the artifacts. And of course, it's very important to instruct patients not to move and follow the breathing instructions before any CT, whether it's chest or abdominal CT. And then of course, for most routine abdominal CT, we should try to keep a pitch of 1 or higher, and then the rotation time preferably should be between 0.5 to 0.8 seconds. In obese patients, you may have to actually use a smaller pitch or may have to increase the rotation time to 0.8 to 1 second. And that typically would happen in patients who are more than 300 pounds, or have a very high body mass index. And then again, one other thing that is important is that the reason why we see the lesions at different dose levels and the reason why the conspicuity of lesions vary by the dose is also contrast agent. So if there is a choice between using non-contrast versus contrast CT for routine abdomen, we should perhaps use contrast enhanced CT, certainly for those young patients or smaller or average size patients, because it will help accept the lower dose images. Now, as I said, we should be using automatic exposure control technique because it will help dial the dose down when you have smaller or average size patients, as here you can see that 3 milligray image at 50 MAS is perhaps acceptable. It's a bit noisy, but it's okay. And then it will help dial the dose meter up or dial the doses higher when we have very large patients. As you can see here, this was done at 23 milligray, which is fine. Even at 14 milligray, this image looks fine. A little bit noisy, right? But at 50 MAS, basically, or 3 milligray, this is just too noisy as against this small patient, basically. So we should be using automatic exposure control technique in all patients who undergo routine abdominal CT. Now, this is an example of a liver lesion, which was basically seen in this cadaver, and this cadaver was scanned at 5 different tube current level from 24 milligray to 1.7 milligray, and you can see that the liver lesion is actually well seen at 24 and 14, obviously much higher doses for this kind of an average size cadaver. But then it begins to deteriorate at 1.7 to 3.4 milligray. It's perhaps okay at 7 milligray, which is what the dose should be for this average size patient. Now, this is the pathology specimen of that liver with the cyst here. Now, this is a kidney lesion here in the right kidney, low attenuation, and again, as you can see at 24 and 14 milligray, and this cadaver, you can very clearly see the margins and the location of that lesion. At 1.7 milligray, this is not seen, and even at 3.4 milligray, it's considerably smaller, and one would guess perhaps, if we did not have the luxury of higher dose images, whether it's an artifact or not. So compared to a kidney stone, which was clearly well seen, at this dose level, you cannot see this low contrast kidney lesion. CT hematuria is another important protocol. The dose does go higher as compared to routine abdomen CT because we are requiring at least two phases, a non-contrast and then a post-contrast, right? For non-contrast, we reduce the dose by actually limiting the scan from the top of the kidney to the pubic symphysis. And of course, we use automatic exposure control technique, and we should be using much lower radiation dose for this non-contrast phase of CT hematuria because we are looking for blood or kidney stones, both of them being high contrast situations. So typically, we should use a kidney stone protocol when we are doing this non-contrast CTU phase. Well, if we have to do a post-contrast CT, then we will have to basically increase the coverage. Sometimes we'll go from the top of the liver to the pubic symphysis. And then the other thing is that different papers and different institutions use different protocol for evaluation of patients with hematuria. And many places actually do 2 or 3 phases of contrast enhancement. We actually do only 1 phase post-contrast, in which we actually use split bolus technique to acquire 1 single phase. We administer 50 ml of contrast, and then we give saline 250 cc's generally. We wait for about 15 minutes. We put the patient back on the CT in prone position, and then we administer a bolus of 100 ml of IV contrast at 3 cc's per second, and we start the scan at 100 seconds. This helps us to get the excretory phase, or the pelvis and the ureters and the bladder, from the contrast that was given 15 minutes back, and then also get a nephrographic phase of contrast enhancement in the kidneys from that 100 cc's of the contrast that we administer to the patient. So, and typically that is sufficient to make the diagnosis and actually avoid acquiring 3 or 4 phase exams for this particular. For appendicitis, again, something that is not so infrequent in young patients, the dose reduction basically will happen by limiting the scan acquisition from L3 vertebral body to the symphysis pubis, right? And then again, we have to use the automatic exposure control technique in these settings. Now, there have been papers in the literature which have demonstrated that you can actually use a very small MAS, like 30 or 40 or 50 MAS, and you can diagnose these cases of appendicitis. However, it's very important to remember that that small MAS may not give you proper images in patients who do not have much abdominal fat, because if the patient does have appropriate amount of fat in the abdomen, then you can see some periappendiceal changes. But if patients do not have any fat whatsoever, sometimes at very low dose levels, you may not be able to even see the appendix or any periappendiceal changes. Now, in summary, there are indications in the abdomen where we may have to use higher dose, for example, for evaluation of liver masses or pancreatic masses. And in other situations where there is high contrast in the abdomen, for example, things that can happen with CT colonography, kidney stone evaluation, or CT angiography, we can actually go lower on the radiation dose by either using automatic exposure control technique, combining it with iterative reconstruction technique, and recently also with use of lower tube potential or lower kV technique. But it's important to balance the dose in the abdomen or dial up or down the dose meter for different indications of the abdominal CT. Thank you.